So now we're going to talk about psychotherapeutic drugs. First, we're going to talk about drugs to relieve anxiety. Earlier, I talked about benzos, benzodiazepines, indapam. PAMs, they depress the central nervous system. Well, if you have anxiety and your brain is kind of going, all a twitter because you have anxiety, diazepam helps put the brain to sleep, calms it down. If your brain is more calm, you're going to be less anxious. But it can be used for multiple things. Again, seizures, status epilepticus. If you're having a seizure, I can give you diazepam. It's going to stop that seizure right now. It's going to put your brain to sleep. But what happens when you put the brain to sleep? You stop breathing and your blood pressure tanks, okay? So these things these medications are not without issues or problems. So I want to make sure that I'm monitoring very, very closely people that I'm giving benzos to because it can tank their blood pressure and make them quit breathing. Alcohol withdrawal. If you're stopped taking alcohol and we're concerned about withdrawal symptoms, diazepam calms the brain down to stop the withdrawal. So then you become addicted to the benzo, but whatever. We can use it to sedate you preoperatively before you have a procedure, what have you. It can be given by multiple mechanisms. It has a short half-life. It basically puts the limbic system in the brain to sleep, puts the brain to sleep, and if you take it, you'll be a happy camper. Adverse effects: drowsiness, dizziness, sedation, amnesia, confusion. If you overdose, you'll stop breathing, cardiac arrest, and or if you don't go into cardiac arrest, you'll tank your blood pressure. By the way, when I say tank your blood pressure, it means lower. It's going to be too low to perfuse tissues. Some people, there can be paradoxical effects. That means the opposite. You expect when you give a benzo to someone that they get tired and go to sleep. Some people, for some reason, when you give them benzos, it makes them crazy and bounce off the walls. It's about 1% to 2%. Contraindications, precautions. If you have psychosis, it could make it worse. If you're on other CNS depressants, which the biggest CNS depressant is alcohol, so you should never mix alcohol and benzos together. It can cause birth defects, and it can cause its own dependency and withdrawal. It interacts with anything else that depresses the CNS and can lead to death. And if your patient is restless, confused, or agitated, evaluate before giving. And avoid using other CNS depressants. You obviously don't want to drive if you're taking this. So that was for anxiety. Now let's move into mood disorders. Mood disorders are an imbalance or dysregulation of neurotransmitters in the brain. Our two major mood disorders that we talk about are depression and bipolar disorder. Some you may hear it called bipolar mania or manic depression, but the term that we've got here is bipolar. There are three main categories we're going to talk about: SSRIs, tricyclics, and monoamine oxidase inhibitors. Let's talk about SSRIs first. We're talking about SSRIs first because, first of all, what you got to remember is SSRIs are your friend. SSRIs are the newest class of medications used to treat depression. They have a great safety profile. They're not without risk, but they're better than the older stuff. They're a newer class, better safety profile. They work well. Patients normally tolerate them well, so SSRIs are your friend. Our prototype is fluoxetine. Selective serotonin reuptake inhibitors, obviously they work on serotonin in the brain. And basically, well, I'm going to talk about that on the next slide. We'll talk about how there's reuptake. And SSRIs are the preferred over other classes. This is normally where we start. If you go into the doctor or a healthcare provider and you have symptoms of clinical depression and they decide to medicate you, this is the first line drug that they're going to use because it has less side effects when compared to other classes. Now, what we have here is we have the neurotransmitter coming from nerve A, and it needs to go across the synapse to nerve B. And we have those little circles, which are the neurotransmitter. The little squares are the reuptake thing. So when the impulse is going this way, the neurotransmitters go out and go across. And so what we're talking about here, obviously, is serotonin. The little circles that don't make it or just kind of hanging out, normally they get sucked back into these boxes for the next time. So what we're doing now with an SSRI is we are blocking that effect, so this serotonin stays in the synapse. As it stays in the synapse, it's more likely to go over here and stimulate across, and that's how it treats depression. It allows for the presence of more serotonin in the synapse. Depression is associated with not having enough serotonin. So if we can allow serotonin to hang around and actually work for us better, it helps treat depression. So fluoxetine is used for depression most generally. It also can be used for obsessive compulsive disorders, panic disorders, bulimia, and premenstrual dysphoric disorder. I'm not even sure I know what that means. Mechanism of action, it blocks the reuptake of serotonin as I just described, so it helps treat depression. But while it's a really good med, has a great safety profile, works well to treat patients with depression, it's not without its own issues. It can cause weight gain, sexual dysfunction, insomnia, anxiety, dizziness, drowsiness. It has less side effects than other classifications, but can cause anticholinergic and some cardiac effects in some patients. What do I mean anticholinergic? Anticholinergic effects are Parkinsonian traits. So earlier we talked about Parkinson's disease and the cogwheel rigidity and movement problems. This would mimic that. So if you have a patient who's on fluoxetine but looks like they have Parkinson's, they probably need to come off that medication and be moved to something different, because that muscle disturbance, that Parkinsonian movement can be permanent. So here's the thing, black box warning, danger, 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 is that there is a thought and a theory with treating patients who have suicidal ideations, but they are depressed, that they do not actually carry out the suicide attempt because they are depressed, and so they are physically and mentally too tired to actually move forward with trying to do it. So if they have suicidal ideations and we now help treat their depression and suicidal ideations are two separate concepts. You can have one and not the other, or both. So if you are depressed and have suicidal ideations and we treat the depression and you feel better, you may still have the suicidal ideations and you may actually try to carry them out. So patients have to be screened for suicide risk prior to the administration of these medications, because we don't want people committing suicide. This is especially true in children and teens and young adults. And it is a black box warning. The next class is tricyclic antidepressants. Tricyclic antidepressants work in order to decrease the reuptake of norepinephrine and serotonin in that synapse in the same way SSRIs do, but by a different chemical mechanism. And because of the way that it works, tricyclic antidepressants, they're an older class of medications, they have more side effects. But still, we may use them for insomnia, migraines, neuropathic pain that's coming from the neurons. There's another one called imipramine that we may use for bedwetting, or also known as nocturnal enuresis. So if you're 40 and you pee the bed, you may be given imipramine. So tricyclics can be used for depression, but they're not first line. SSRIs are your friends, so they are first line. Amitriptyline is second. Adverse effects of tricyclics are sedation, those anticholinergic effects that we talked about, those Parkinsonian traits, and they are much more common in tricyclics than they are in SSRIs. And the list of other things that are here, obviously, you guys can read. Well, I guess that's it on tricyclics. Now we're going to move to monoamine oxidase inhibitors, MAOIs. MAOIs, third line, dangerous. That's why they're third line. They're more dangerous than the other two classes. Selegiline is our prototype drug, and they work on dopamine, norepinephrine, serotonin in the neurosynapse by inhibiting monoamine oxidase. They're rarely used. Why are we talking about them? Well, because they are still used. I said rarely used. It doesn't say never used. But they are a third-tier drug because they are dangerous. And they're dangerous because in addition to their own side effects, they also have drug-food interactions. So any food that is rich in tyramine can interact with an MAOI, which now here it's phenelzine. So selegiline or phenelzine, they're both MAOIs, so they're the same thing. And this is an NCLEX question. They're going to give you an MAOI inhibitor, and you've got to pick the food that's rich in tyramine. Because if you give this with a medication, if you give this medication with a food that's rich in tyramine, it causes a hypertensive crisis that can cause them to stroke out and bleed. Bleed to death in their brain. And what I mean by stroke out is not an ischemic stroke. It's going to cause a hypertensive crisis. It's going to cause an aneurysm to pop in your brain, and you're going to bleed out into your brain and die. So it's no good to take with tyramine-rich foods. You also can't mix it with other medications like SSRIs or tricyclics. If you mix them together, you're going to die. So if you're on an MAOI and we need to get you off of it and then use another class of drug, they have to take you off the MAOI slowly over a period of time, and then once it's out of your body, reintroduce the new medication. So you may have to actually be hospitalized in order to come off of it. There are over-the-counter drugs like St. John's wort. St. John's wort is an SSRI. It's chemically related to Prozac or fluoxetine. So it can it's no good. Ginseng root, L-tryptophan, all those things will interact with it. So it has multiple food and drug interactions. So you should wear, if you're on it, you should wear a medical alert bracelet in order to tell people. So food restrictions. These are all things that are rich in tyramine. Aged cheeses, meats, or sausages. Cured or fermented foods. Okay, so this includes bacon. You can't eat bacon if you're on an MAOI. So Joe will never be taking an MAOI. Beer on tap has tyramine, but canned or bottled is okay. Bananas, avocados, chocolate, caffeine. So you can see all these wonderful things you cannot eat if you're on an MAOI, because if you did, you can die. So that is MAOIs. Let's move on to mood stabilizers. If you think about depression through the idea of poles, and this is depression. That didn't work very well. This is depression, and this is mania. And in between, ideally, you want to be here. You don't want to be depressed, and you don't want to be manic. You want to be in the middle, right? In the happy place. Patients with bipolar disorder will swing wildly from one way or to the other. Okay, they may have periods of mania, or they may have periods of depression, and we want to try and get them to the middle. And the way we do that is to use medications in order to help them lead productive lives and to try and get them there. So what's the difference between mania and depression? Mania is you're irritable, loud, running around, kind of like me when I lecture. I'm a little bit manic. Delusions, grandiose, flight of ideas. They just list stuff off and don't stop talking. The opposite of that is depression, where it's like you're tired, you want to sleep, you don't eat, you just it's like you're wound down and deflated. Where we want to be is in the middle. And one of the drugs that can help us get to the middle and to keep it stable is a mood stabilizer called lithium. Problem with lithium, it has a very narrow therapeutic index. You have to keep it in a therapeutic range or you end up with side effects and problems. This is our normal therapeutic index, 0.6 to 1.2. That's your maintenance. But if you are in an acute manic episode, we run you a little bit higher until we get you controlled, and then we bring you back down to the lower levels. Patients need to have frequent levels drawn. We measure it every 8 to 12 hours after the last dose. You need to have frequent levels done. We will measure it 8 to 12 hours after the last dose, which is approximately the midpoint of the drug's half-life. The half-life is 18 to 24 hours. So this is a once-a-day dosing medication. The other thing to know is that there is a diet restriction. Sodium and lithium compete for reabsorption in the kidneys. So however much sodium, if you're eating X amount of sodium in your diet every day, when we get you to your therapeutic level of lithium, you have to stay on that same amount of sodium in your diet every day, because if you alter it, you will alter the reabsorption of lithium in the kidneys, and you can raise and lower the therapeutic index of it in your blood by dietary factors. So what you need to know is you need to have a stable sodium level while you're on lithium. So wherever it is we get you to your therapeutic level is how much you need to stay on. So when the intake of sodium is low, less lithium is excreted, which means your blood levels of lithium would go higher. And we don't want that. We want them to stay stable. So if you never eat McDonald's French fries and then all of a sudden you start eating McDonald's French fries, that's too much sodium and it's going to cause adverse effects. Okay, so they need to have normal sodium levels over a period of time. So it works to prevent mania. Basically, it's an anti-manic, which helps keep you in the middle. But what it can do is cause increased thirst and urination. Well, what's the problem with that? Alters sodium, doesn't it? So sodium is an important factor. So however much you're losing needs to be replaced so that we keep you level on sodium. Toxic things that can cause seizures, coma, permanent damage. So it's not without side effects, but they are generally well controlled, and diet is an important factor. If you have severe cardiovascular disease, kidney disease, or if you're pregnant, breastfeeding, or have a sodium imbalance, you can't take lithium. So after diarrhea, diuretic use, dehydration lowers your sodium level. If it lowers your sodium level, it's going to lead to toxicity because more lithium will be absorbed. So additional things that we may use for mood stabilization, in addition to using lithium, they may have other medications that are added on, and here they are. Valproic acid. Valproic acid can also be used for seizure disorders, but it also can be used as an adjunct for psychotropic medications. Lamotrigine, it is used for recurrent mood disorder episodes. It's a maintenance medication and also can be used for seizure disorders. So now we're transitioning from mood disorders to psychotic disorders. And the thing that you got to know about psychotic disorders is that, and what we're talking about here is schizophrenia. Okay, schizophrenia is a psychotic disorder, and schizophrenic patients they're not in touch with reality. They actually have things going on in their brain, and they're not sure which of the 20 things happening in their brain is actually real life and which one is the thing in their head. They have difficulty in differentiating between those. And the drugs we use to treat them, we classify them as conventional or first generation, or atypical or second generation. And psychosis is the inability to decide what is reality. And imagine that as you're sitting here listening to me talk, you also have 20 other voices in your head, and they're all saying 20 different things. Okay? And sometimes the problem is, what if one of those voices is telling you, burn the house down, burn the house down, burn the house down, and you don't realize that the voice telling you to burn the house down is not real. It's a voice in your head. You may actually act on it and burn the house down because the voice in your head told you to. So in addition to acting out and doing things that are, psychotic, patients with these disorders also have trouble with interacting and concentration. Imagine studying and trying to listen to the voice in your head that's helping you study while there's 20 other things happening all at the same time. You can't do that. So it's very difficult to function in the real world. So the goal is to decrease that altered functioning and try to bring you back to only one voice, and that voice is the voice of reality. And so the thought, by the way, is that, and we're going to talk about haloperidol, and the thought is that psychosis is caused by too much dopamine. It's kind of like the opposite of Parkinson's. So if you have too much dopamine, you can have psychosis, which is why when we give levodopa, it can cause hallucinations, because it's increasing the dopamine in the patient's brain who has Parkinson's. So now you understand why they can have hallucinations, because sometimes maybe too much gets absorbed, and then they end up having hallucinations. So there you go, tying those things together. So haloperidol can be used for psychotic disorders. Also can be used for Tourette's. And so because it's thought that we have too much dopamine, it blocks dopamine. So it helps to treat those effects. But the problem is that this is a conventional first generation, causes lots of extrapyramidal side effects, those Parkinsonian type traits, because it's affecting dopamine functioning in the brain. And if we're blocking the dopamine, we already know that if you don't have enough dopamine, you end up with Parkinsonian traits. So these drugs cause those extrapyramidal EPS, extrapyramidal side effects that are Parkinsonian traits. Another primary reason or effect is that if the voice in your head is telling you don't take your medication, you might not take your medication. That's why we have a nursing implication, observe for cheeking. Patients who you're giving them their medication, they're going to pretend they're going to be they could be paranoid as part of their delusions from their psychosis. And if the voice in their brain is saying, the nurse is here to kill you, don't take the pill, the nurse is here to kill you, don't take the pill, they're going to take the pill in their mouth and pretend like they swallowed it, but not really swallow it. As soon as you're out of the room, they're going to spit it out. So you got to make sure that it actually went down. Pseudo-Parkinsonism, or extrapyramidal side effects, or EPS. Actually, I would encourage you to go to YouTube and type that in and watch videos. and also type in the word tardive dyskinesia. And the problem with tardive dyskinesia is if it happens and goes for an extended period of time, it can be irreversible. So these traits that you would see when you go YouTube this are potentially for life. The conventional antipsychotics can also cause neuroleptic malignant syndrome. It's rare, but it can happen. And these are the signs and symptoms that you'll start to see. And these patients have to be taken to the ICU and put on drips and on a ventilator. We have to bring their temperature down. We have to paralyze them and sedate them and do all kinds of things to try and keep them alive. Most people who develop neuroleptic malignant syndrome die, but we try to save them as best we can. And some people do live, but like I said, most die. And it is a potential side effect. Luckily, it's rare. Whoops. So options to minimize adverse effects. By the way, I said whoops because I clicked something on my computer and I think it did, you couldn't see it, but I could. So anyway, we're back. So to minimize adverse effects, those extrapyramidal side effects, there's drugs called benzotropine, may be used to try and control them. And so again, it doesn't fix the problem, it treats the symptom. Newer classes of antipsychotics, second generation atypical antipsychotics, these are the newer ones. This is clozapine. Clozapine has a little bit better safety profile. It has less side effects. And so it's preferable because it has less side effects. It can be used for schizophrenia, dementia, Parkinson's, psychosis. And again, it's working on that dopamine in the brain. What you need to know about clozapine as far as monitoring is down here at the bottom, this agranulocytosis. Agranulocyte. So A means absence of. Granulocytes are white cells, so it means you have a low white blood cell count. Patients who are on clozapine have to have a white blood cell count drawn on a regular basis. Okay. If their count goes too low, they may have to stop the medication. And so at a minimum, they're going to have the white blood cell count checked at least weekly for the first 6 months that they're on the medication. And then every 6 months thereafter, they're going to have a redraw. Okay, so patients who are on clozapine, we want you checking their white count because it can cause agranulocytosis. Going back here, clozapine. So clozapine is second generation antipsychotic. So everything that was first generation antipsychotic could happen with a second generation. It's just that with second generation, it's less likely. It does not happen as often with second generation as they do with first. And what's special about the second generation or atypical is they also have the added thing of agranulocytosis with regular blood monitoring. Acetylcholinesterase enzyme inhibitors, donepezil, these are medications used for to try and treat patients who are developing Alzheimer's disease. It's not a cure. It is designed to slow the progression of the disease. I will tell you that my personal experience is that by the time the symptoms are enough that the patient goes for treatment, it's probably almost too late. And so a lot of times these medications are added on far too late. So there isn't a lot of benefit that I've seen clinically to them personally, but obviously they do something or they wouldn't, be out there at all. But the earlier you start them, the better the benefit. And because again, they're not a cure, they're just slowing progression. So donepezil is for mild to moderate Alzheimer's disease. Its adverse effects, it can cause all kinds of different GI symptoms: headache, insomnia, bradycardia, and syncope. Syncope means you're passing out, that for some reason your perfusion to your brain decreased, and probably the reason that you had the syncope is because you're bradycardic. Your heart rate gets low enough that it doesn't perfuse your brain and you pass out. Those are the most common adverse effects, but it's not common. The presence of adverse effects with this medication, the numbers are low, but when they do happen, this is what they are. So you want to detect and correct any treatable factors that can contribute to their cognitive impairment. So when somebody has an onset of cognitive symptoms, they usually do a panel of diagnostic treatment, like, I guess diagnostic isn't treatment, a battery of diagnostic testing in order to determine what it's not. Okay, so like if you go in and you're having signs and symptoms of dementia or Alzheimer's disease, they're gonna draw blood to check you for syphilis, right? Because syphilis can cause cognitive deficits. So they're gonna say, okay, the reason for the cognitive deficit is not syphilis. The reason for the cognitive deficit is not a stroke. Okay, so the diagnosis of Alzheimer's disease is a diagnosis of exclusion. You've excluded all these other things out, and so then the only thing left is the Alzheimer's disease. So we detect and treat anything that can be treated and rule those things out before we go down the path of the donezepil, because the donezepil isn't going to help you if the reason for your confusion is syphilis. Obviously, if you have syphilis, you need a different kind of treatment. Okay, so we do the diagnosis of exclusion first and then go down and treat. So patients with dementia-type disorders like Alzheimer's need frequent small meals to help offset the GI side effects. They also need frequent small meals because they need the calories, because they literally will be eating their food and they'll forget what they're doing while they're doing it and get up and walk away and wander around. People with Alzheimer's disease love to wander. And so what you've got to do is have like little finger foods. So part of your care plan is you have this patient who has dementia, Alzheimer's, and she wants to wander around in the hallway, is you let her wander around in the hallway with limits, when people watching her, and then you have little finger food sandwiches and you hand one that is like bite-sized, that you eat it and go, and you do that multiple times a day in order to get the calories in. Because if you actually just put a whole meal down, they're going to bite into it and eat a couple bites, and then they'll be like distracted and go off and do something else. So there needs to be frequent small meals for two factors: that it helps with their GI symptoms of the medication, and also it helps get the calories they need because they can't finish a full meal. And we need to make sure we're monitoring weight. We don't want weight loss, we want weight gain, because weight loss is a huge factor in patients with Alzheimer's dementia. And that is the end. Thank you very much.